And it really comes down to, it is impossible to ever truly know your caloric expenditure for an hour, much less for a day or for weeks or months. You're literally picking a number at random in the dark. And so, but insulin is something that's very concrete. Fat burning, that's what I'm all about, right? Is to help you burn fat. If you want to lose weight globally, if you want to lose bone density, if you want to lose muscle mass, then calorie restrict, because you'll lose fat, but you'll also lose bone density and muscle, and you'll lose cartilage and tendon and sinew.
Yep, starvation is a wonderful way to waste away.
Yes, but you're not going to just burn fat or lose fat. If you'd like to just lose fat and keep your muscle and keep your bone density, then you have to think about the hormone model of fat burning, and that's what Dr. Bikman's all about.
I am unaware of any situation where a person can lose weight unless insulin is low. I am unfamiliar of any situation where a person can gain weight unless insulin is elevated. But actually just indicating that not only is insulin actually changing the actual biochemical handling of fat in the body and the fat cell, but it also changes metabolic rate. We published a study in 2018, which even then was supporting studies from 20 years ago and even 100 years ago. We have known that if you give a type 1 diabetic who is initially insulin deficient, you give them insulin, their metabolic rate will slow by about 300 calories per day. We are just finishing the work to publish our paper finding that ketones, which I don't mean to introduce yet if we don't want to, in contrast are stimulating metabolic rate. And both of this, insulin and ketones, are having an effect directly at the fat cell, stimulating the fat cell to be more or less active.
We've established over the last, since about the 1960s, that the calorie in, calorie out model, eat less, move more, that doesn't work. But that has went hand in hand with our obesity epidemic.
So I define insulin resistance as two things. One, insulin isn't working the same way as normal in the various cells of the body, and that is a particular part of the disease state. In some cells, insulin is working the same as ever. In some cells, it is not. And that, again, the combination of that ends up being particularly problematic in light of the fact that the second aspect of insulin resistance is, as you state very accurately, the hyperinsulinemia. You cannot pull those two apart. Insulin resistance is hyperinsulinemia, and that is so profound in its simplicity because it changes how we detect diseases or diagnose them, and it changes how we treat them. We look at type 2 diabetes as a glucose disease, but in so doing, we detect it far later and we treat it far worse. If we look at type 2 diabetes as an insulin problem, well then over the years, the insulin's been climbing, the hyperinsulinemia of insulin resistance, but it's enough to keep the glucose in check. But this right here is so important because so commonly we say that type 2 diabetes, your beta cells aren't making enough insulin. The glucose starts to climb and then we detect the problem. But the truth of the matter is in type 2 diabetics, they still have far more insulin than the average person. It is just not enough, so-called, to keep the glucose in check. It's because the pancreas simply can't make enough. And so in that situation of the steadily climbing glucose and insulin, the average clinician will say, well, we don't care about your insulin, so we're just going to bump it up even higher, give you insulin injections because we know it'll push down your glucose. Yeah, it'll push down the glucose, but it'll make the person fatter and sicker than they were before.
Many doctors, even if you're overweight, even if you're pre-diabetic, you go to your doctor for your annual checkup and they'll check a very basic panel of lab work. Your glucose is normal. And so at that point, your doctor stops looking. But the problem is that your insulin level, in order to keep your glucose normal, is sky high because you're eating too many carbohydrates. And so you literally, if your doctor knew to check a C-peptide and to check a fasting insulin, they could actually diagnose your prediabetes or your hyperinsulinemia up to a decade early and say, you, my friend, are about to develop type 2 diabetes. I can tell because your C-peptide is so high. Even though your blood sugar is still normal, we've got to change your diet before you become a pre-diabetic or a type 2 diabetic.
So much of the focus on aging these days is to control a protein in the cells called mTOR.
Yes.
And that has led many to say, oh, well, dietary protein increases mTOR, so that if you want to keep mTOR down and age really well, then eat less protein. And the actual human evidence throws cold water on that idea, because we see that the people, as they age, that eat the least amount of protein have the higher mortality. So that doesn't hold up. But even still, that idea of you want to keep mTOR less activated, and then you're going to age well, then all the more reason to control insulin, because insulin stimulates mTOR far more than amino acids do from the dietary protein. So aging is related to insulin potentially. Cancers, we know that breast and prostate cancers are incredibly responsive to insulin. Indeed, if you pull a biopsy of a normal breast tissue and compare it to a biopsy from a breast tumor, the breast tumor has 7 times more insulin receptors in it than the normal breast tissue. That means it is 7 times more responsive to that insulin. And what does insulin do? It tells cells to grow. You don't want a cancer cell to be told to grow. And of course, it's stimulating that growth. And then I'll just mention another one just because it might be unexpected. Even fertility, polycystic ovarian syndrome, something I know you're familiar with in your practice because it's so common, indeed the most common form of infertility in women. It at its core is a disease of too much insulin, where the insulin is inhibiting the conversion of sex hormones in the ovaries. So this woman's ovaries end up overproducing androgens, like testosterone, that should have been converted into estrogens. That's just a basic truth of physiology, that all estrogens were once androgens. So they come from testosterone. That's how it's supposed to be. But that conversion isn't happening. So her ovaries are pumping out a lot of testosterone when they should be pumping out a lot of the estrogen.
The PCOS example, many doctors will focus exclusively on the testosterone, right? And they'll actually give the patient spironolactone and other things to try to lower their testosterone. And so literally what they're doing, the root cause is up here, the insulin, but they're trying to work down here and work on this. And it completely ignoring the kind of the watershed cascade.
Yeah.
It's all being caused by hyperinsulinemia. It's not. And so once you fix the insulin, everything else in that cascade goes back to normal. We've heard it from thousands of women online on social media who said, yeah, as soon as I had lowered my carbohydrate intake, got my insulin levels back to normal, I got knocked up.
I like to compare most chronic diseases, imagining them as branches coming off a common trunk. And if we are continuing to try to hack at these branches with various medications. For example, if someone has PCOS, there's going to be a distinct medication for that. The same person could have diabetes, that will be a distinct medication. They could have hypertension, that'll be a distinct medication. So rather than having the patient leave the office with 3 prescriptions, the result of which will just be a lifetime of increasing the dosage, instead of change the conversation and say, actually, all of these are coming off of one common trunk. Let's just chop down the tree rather than hacking away at the branches. And at the risk of seeming opportunistic, it was seeing health and disease this way that prompted me to write the book, Why We Get Sick. If anyone's interested, it is just all about insulin resistance, what it is, how you get it, why it matters, and what to do about it.
I mean, I can't tell you the thousands of people who have reached out to me who used to be on 1, 2, or 3 blood pressure medicines every single day. And every doctor, what do they want to talk about if you have high blood pressure? They want to talk about lowering your salt intake.
Oh, geez. Yeah.
Which is just the dumbest paradigm in the world. Your high blood pressure, almost 100% of the time, if they check a C-peptide or fasting insulin, it immediately becomes apparent that the hyperinsulinemia is the reason you have hypertension. And so if anybody's listening with high blood pressure and you've got access to your labs on your lab portal, log in and see if your doctor has checked a C-peptide, the letter C followed by the word peptide, or a fasting insulin. If those labs haven't been checked on you, then your doctor is still ignorant of this paradigm. And I don't mean your doctor's dumb. They just haven't shifted their way of thinking yet. And Dr. Bikman and I are working on that right now. But when they finally shift their paradigm and go, so, I see the cascade now. So insulin being chronically high leads to this, and that leads to this, and that leads to the hypertension. And that's so the fluid retention, the sodium retention, and then you have high blood pressure. It's not actually the sodium doing that. It's the insulin. Once your doctor has that epiphany, your doctor's going to change how they treat hypertension for the rest of their career. So it's not only going to benefit you as their patient, it's going to benefit every one of their patients. And that's why it's so important that you share this information with everyone you know who needs it.
It's one thing to be eating salt. The kidneys are designed to deal with that salt. And insulin doesn't let it do it properly. And insulin's forcing the kidneys to hold on to that salt, which is holding on to water, and blood pressure just stays high. But it's also why people have such significant drops in blood pressure so quickly when they adopt dietary changes. If they look at their hypertension through the lens of insulin, then they just intuitively would say, or logically, how can I lower my insulin? All right, of the foods I eat, of the 3 macronutrients, of course, carbs spike insulin the most. I'm just going to start eating less. Boom. Blood pressure plummets just right lockstep with insulin coming down as well.
Early in my practice, when I was starting to recommend the ketogenic way of eating to my most morbidly obese, most metabolically ill patients, they would come back anywhere from 2 weeks to a month later and say, Doc, I don't think this diet is right for me. Every time I stand up, I get lightheaded. That means that we can now stop one of your blood pressure medications. But so many people so often, they become wedded to their medications. Like it's a part of them, right? Like I have to have my pills. And when I say, no, that's good, that means it's time to stop 1 or 2 of your blood pressure medications. You should see their face light up. It's the most beautiful thing. They're like, oh, I didn't think of it like that. I just love that so much.
I compare caloric fasts to nutrient fasts where But you're sort of alluding to this as well in the form of what we could also call a fat fast. I've heard Megan Ramos, who works with Jason Fung in their fasting protocol, call it that, and I think it's totally accurate. I define a fasted or a fed state based on the effect of insulin and glucagon. Insulin is the hormone of fed state or eating and storing energy. Glucagon is the hormone of fasted state and using energy, not storing it, mobilizing it to be used by the body. So if we look at the fat cell, for example, or glucose that is stored in the liver, insulin is telling the tissues to pull in glucose and fat and hold on to it. And it's also telling the liver to make fat from any glucose, from any excess glucose as well, and store that or send it out to be stored in the fat tissue. In contrast, glucagon is breaking down that stored glucose, that stored fat, to be used by the body. So if we look at fasting or feeding in the context of insulin and glucagon, a fasted state has very low insulin, very high glucagon. A fed state has high insulin, low glucagon. And we can measure this ratio based on just looking at insulin and glucagon. And importantly, if someone is adhering to a ketogenic diet, which of course, as everyone knows, is a very low carb diet, their insulin to glucagon ratio or the insulin and glucagon levels are much closer to a true fasted state when you're not eating anything than it is to a typical fed state when the feeding is based on the standard American diet, high fat, high carb. So that is one of the other reasons I am an advocate of a low carb diet, because it continues to provide the benefits of fasting while acknowledging that a fast always has to end. You can't fast indefinitely. Right. So don't break your fast, really. I mean, you put something back in your guts, but you're still keeping the body in that state of energy use and energy mobilization.
Physiologically, medically speaking, there are essential fatty acids that you have to get from fats. If you don't get them, you will get sick, you will suffer, and you'll eventually die if you don't get them for a long enough period of time. There are essential amino acids that come from proteins. If you don't get these essential amino acids, you will get sick, you will suffer, and you'll eventually die if you don't get them in your diet. But there is no essential sugar. There is no essential starch. There is no essential carbohydrate, to my knowledge. A ketogenic way of eating, in my way of thinking, is a fasting mimicking diet. If you're doing it at a low enough carbohydrate intake level, it mimics fasting, all the benefits of fasting, including the autophagy, including the reduction in inflammation, and including the increase in fat burning. You get all of that with a ketogenic way of eating without just fasting.
Yep. Well said. I agree wholeheartedly.